Global acute malnutrition is a major underlying cause of death and illness, affecting about 52 million or 8% of children under 5 worldwide. It is relatively more prevalent in low-income to middle-income countries. Addressing moderate acute malnutrition, especially in developing countries, most especially in low and low-middle-income countries, can help in preventing more severe acute malnutrition cases to progress and for child mortality to decrease. The Department of Health, in partnership with World Food Programme and United Nations Children's Fund, launched the first ever national guidelines for the management of moderate and severe acute malnutrition in children under 5 years of age. To establish the management of moderate acute malnutrition, both by prevention at the early onset or treatment of nearly severe cases among children in the Philippines from 6 months to 5 years of age. Maximum coverage. To bring to treatment as many people as possible with the most affordable and accessible services available. Timeliness. To detect acute malnutrition early and start treatment before the onset of life-threatening conditions. Appropriate medical care and nutrition rehabilitation. To ensure the efficiency of programs and services on nutrition, it is important to provide the proper treatment of cases by the proper providers. Care as long as needed. To reduce barriers to access and ensure that children stay in the program until they recover. The key components are community mobilization, inpatient therapeutic care for treatment of severe acute malnutrition cases with medical complications, outpatient therapeutic care for the treatment of severe acute malnutrition cases without medical complications, and management of moderate acute malnutrition through targeted supplementary feeding program. These components are interlinked with each other. Community outreach and mobilization, which entails promotion and community involvement in programs combating wasting through the processes of assessment, sensitization, case finding and referral, and case follow-up. Under the health system and services fall the outpatient therapeutic care and inpatient therapeutic care components, both for the management of severe acute malnutrition. Severe acute malnutrition cases without medical complications are brought to the outpatient therapeutic care for weight recovery through the provision of routine medical treatment and nutritional rehabilitation with ready-to-use therapeutic food. Inpatient therapeutic care manages the treatment of severe acute malnutrition cases with medical complications in a hospital or health facility with 24-hour care capacity until such condition is stabilized. The last component handles services and programs aimed at addressing moderate acute malnutrition through supplementary feeding, with the distribution of supplementary foods in the form of lipid-based nutrient supplement, ready-to-use supplementary food, or locally available food with the same nutrient contents. TSFP, or Targeted Supplementary Feeding Program, specifically caters to children under 5 who are qualified moderate acute malnutrition cases for the improvement of their nutritional status to normal. It also serves as a follow-up venue for cured severe acute malnutrition cases. Hello? Hello, good morning. Madunggan ako ninyo? Okay, hello everyone. Thank you for having me here. Naay stages of this community mobilization. So there's the planning phase o ang implementation phase. Ang planning phase dire under ang community assessment, community sensitization and dialogue, developing message and materials to be given to the local community, o training community outreach workers. And then after these are the implementation phase like katong case finding referral, follow-up, o recording and reporting. Ang gamit yun sa community sensitization kay we make the local community being aware or educated about the malnutrition. So we give messages, we give flyers, media, and materials containing like example the signs and symptoms of malnutrition, so ang apekto ani sa pamilya, nganong importante nga makita na to dayon kung naay malnutrition ang bata, treatment and services na ilang ma-avail silang community, ug unsa ang mga proseso sa pag-treat kung naay malnutrition ang bata. Oh, good question, no? So based sa tong guidelines sa gihimo, natay 3 methods sa case finding. Mao ang active adaptive, o ang passive na method. So active, pasabot na mo screen ta sa bata, adto silang balay, so mag house to house ta, balay to balay, bahay to bahay, or sa usa ka defined location. Unya, ang kalahian ani sa active adaptive, kay mo screen ta gamit ang locally understood and accepted na description sa acute malnutrition. Ang last method kay ang passive, pasabot mo screen ta sa bata during silang health facility visit or dito silang health center or sa hospital na ilang i-visit or sa clinic. No, I'm very glad that you asked me about this. So, sa guidelines kay, we have criteria. So, ang tools atong ginagamit kay ang mid-upper arm circumference measurement or ang weight for length na gikan sa WHO na chart or presence of absence of bilateral pitting edema. So kami, kung mag-screen mi dito sa local community, kay among dalon ni kaning mid-upper arm circumference nga tape. So napo siya colors, no? Green, yellow, o red. So makatabang ni siya as visualization kung unsa na ang pasabot or interpretation sa measurement sa mid-arm circumference sa bata. Explain lang ko kadali, no? Unsaon ni pag-measure ang mid-upper arm circumference sa bata. So, i-measure nimo gikan sa kaning bony process sa mong shoulder hangtod sa kaning bony process sa imong elbow. Unya, i-measure nimo ang mid-ana, so ang tunga-tunga ana. Imuha na siyang butangan og ballpen as a mark. Unya, diha nga tunga-tunga, diha ka mo palibot sa tape. So, if we classify our patient as severe acute malnutrition, kay we still have to further assess the patient. Kay magting ta if we give outpatient therapeutic care or inpatient therapeutic care to that patient. So, one of the tests to do kay kaning observed appetite test, we have to encourage the child to intake this RUTF. Per dili na to siya pugson nga mo take ani, no? Unya, i-observe na to if makakonsume ba ang bata sa required amount. So, ang pass ani nga test kay ang bata is able to take at least 3 to 4 mouthfuls of RUTF. Unya, fail siya ani na test if the patient does not take at least 3 to 4 mouthfuls of RUTF. So, you might be wondering, no, unsa ning mga medical complications na dapat na to i-assess. So, example ani kay presence of vomiting, so nagsuka ang bata, taas iyahang temperatures, or naay hypothermia. Naglisod siya ginhawa, so taas yung respiratory rate, or na presence of anemia, and then if also na presence of superficial infection, i-check sa nato ang alert na sa patient, kung very weak ba siya, apathetic, unconscious, or na presence of convulsions, o lastly, i-check sa nato, very important kay ang hydration status sa patient. So this outpatient therapeutic care, this provides treatment for children with severe acute malnutrition with adequate nga appetite o no medical complications. So these children can be treated silang balay with simple routine medicines o giving of RUTF or ready-to-use therapeutic food. So one of the treatment for outpatient therapeutic care is giving of routine antibiotics. So, it is routinely given to severely malnourished patients even if they do not have clinical signs of systemic infection. Nearly all, if not all, will have small bowel bacterial overgrowth and minor infections. Also, it is important to check the immunization status sa patient and check for the date of the child's last deworming. And it is also important to note na it is not necessary to give vitamin A because the RUTF has sufficient daily allowance for vitamin A already. So another step is the weekly monitoring of anthropometric measurements and edema check, also for the history, medical examination, and the appetite test of the patient. And also at this time, we can resupply the RUTF and complete the medical treatment. So you can read in the guidelines the criteria for referral to the inpatient from the outpatient treatment during follow-up. So inpatient care for children with severe acute malnutrition with age 6 months to 5 years of age therefore focuses primarily on the nutritional and medical stabilization of the child and appropriate management of medical complications. So this management occurs in 3 distinct phases. So important to note in each phase is that in phase 1 or the stabilization phase, the therapeutic milk F75 is used to stabilize and reverse the physiological and metabolic abnormalities and also to correct the electrolyte imbalances. For the transition phase, this is the transition from the F75 to the RUTF. Also, in this phase, the amount of protein, energy, and micronutrients is increased. So for the phase 2, it is a continued treatment with F100 therapeutic milk or RUTF, increasing the intake as to promote rapid weight gain. Also, I would like to add that it is important to really check appropriate feeding technique being done to the patient. So we have nutritional interventions for the management of moderate acute malnutrition. So we do targeted supplementary feeding programs. There are 3 forms of supplementary food, which are the ready-to-use supplementary food or the RUSF. We have locally prepared foods with micronutrient powder and blended cereals, which are modified in their energy density, protein, fat, and micronutrient composition to help meet the nutritional requirements of moderate acute malnutrition children. So the RUSF is usually given 1 sachet per day or 92 grams per day for approximately 3 months. The locally prepared food with micronutrient powder is usually given once or twice depending on the prepared food, and it's usually given 3 to 6 months. The fortified blended food such as Super Cereal Plus is usually given 130 grams per day or with a ratio proportion of 500 kilocalories for approximately 3 to 6 months. We also do tracking and monitoring for children with moderate acute malnutrition in the supplementary feeding centers. So mid-upper arm circumference and weight is taken every 2 weeks. Height and length are measured at admission, monthly, and if child substitution is suspected. And the weight for length or height can be calculated as required on the day of admission and discharge. As an update to the budget, according to the proposed national budget for fiscal year 2022 by the Department of Budget and Management, we have a budget of 4.2 billion for supplementary feeding program and 250 million for the complementary feeding program. And according to the 2022 Budget Briefer published by the Health Policy Development and Planning Bureau of Department of Health 2021, we have a budget of 2.2 billion for 2022 for the family health, nutrition, and responsible parenting. So I do believe that we still have a lot of things to discuss about the moderate and severe acute malnutrition in the Philippines. However, right now we are pressed for time. So I just suggest and recommend all of you to have a copy of the national guidelines and read everything about it. And this would help in the promotion of public health to fight against malnutrition here in the Philippines. Thank you so much for having me here, and God bless us all.